It's been great hearing about all of the research and experience with telehealth, and I think Alberta has a lot to learn from what's going on in the UK. But today I'm here to share our experience with using telestroke to further acute care treatment, or telehealth to further acute care treatment for stroke. I have no disclosures other than the fact that my talk is 2 minutes too long, but beyond that, nothing else. I'll very briefly discuss the impact and importance of stroke, to discuss challenges in implementing stroke care to rural regions, and the role of the Alberta Provincial Stroke Strategy in doing so. And I'll discuss the experience of Alberta in using telehealth to deliver acute stroke services. So I'll start with a patient presentation. This is actually a patient I encountered while on call. A 72-year-old female smoker with high blood pressure, while at home in rural Alberta, tells her husband she doesn't feel well, and that her right arm has become numb. And then rapidly, in minutes, she's unable to speak, does not seem to comprehend, and collapses to the ground. She has a droop of her face on the right side, and she cannot move her right arm and her right leg. So in 2005, there would have been nothing in regards to acute treatment to offer this lady in Alberta. And there wasn't even the ability to give her stroke unit care or supportive care for stroke close to where she lived. But I'll show you some evidence that things have changed over the last few years for the better. But a few words about the impact of stroke. It's the fourth leading cause of death in North America. It results in 5.9 million deaths in the world per year. Out of everybody who dies across the world in 1 year, 10% die because of stroke. So it's a major global problem. It's a leading cause of disability in adults. And if you look at the pie graph, out of 100 patients who have a stroke, 15% will die on the average, 16% are left with major disability, and 14% with moderate disability. So 45% of patients are left either dead or with a major life, or their life status has changed entirely in regards to their interaction with their family members, their employability, their ability to integrate into society. So stroke clearly needs to be a global priority. I give my cardiology colleagues a hard time saying it's not all as simple as cardiology. So it's not quite 1 or 2 millimeters of ST elevation in 2 contiguous leads with chest pain, leading to an ability to thrombolyse. In stroke, sometimes it is that simple. If there's any cardiologists in the audience, I don't claim the disease is simple at all, but simply the diagnosis part up front. Some stroke patients are that simple to diagnose. It's absolutely obvious, very much like the patient I just presented. But others, it's more complex, and you have to actually look at an undifferentiated neurological syndrome, localize it to a vascular territory, and then make a decision for stroke. If you're going to use a lytic or a medication with potential side effects, which could be substantial, you have to be fairly certain you have your diagnosis well established. The first thing we want to exclude is the kind of stroke that results in 20% of all stroke, which is hemorrhagic stroke. On the left, deep in the basal cisterns, is white where it should be black, and that's blood from a burst aneurysm, which you can actually see right there. And usually this does not present with focal neurological symptoms, but rather a cataclysmic, sudden onset headache. The patient feels as if they've been struck on the back of the head with a club. But the other kind of stroke is intracerebral hematoma, which causes about 15% of strokes. And you cannot differentiate this condition from ischemic stroke on clinical grounds. In fact, this lesion could be causing our patient's syndrome exactly, or it could be from another kind of stroke, which is this kind, ischemic stroke. If you look at the cartoon on the left, it shows a cross-section of an artery, which shows an underlying area of plaque, and a thrombus, which blocks off blood flow and subsequently oxygen supply to the brain. On the CT scan, this is actually that lady's CT scan. What you see here outlined by the red circle is this ghostly white line, feathery white line here, which is a thrombus in the middle cerebral artery that's 4 to 5 centimeters long and completely blocking off blood flow in that blood vessel. You can actually see it on the plain CT scan. And if left untreated, this will announce an extremely severe stroke. So 1.9 million neurons die per minute in ischemic stroke. Stroke neurologists are a very tense and time-sensitive lot. We're always concerned about the time and watching the clock for every minute and on everybody's case to move thrombolysis forward as quickly as we can. And this is why. It's 1.9 million neurons per minute die every minute that artery is blocked. What we want to avoid is this nice, appealing-looking, homogeneous gray brain tissue turning into this black necrotic mass on the left side. And if this were a stroke allowed to complete, a cerebral infarct like this would produce language problems, paralysis, and it would have a 40% mortality rate at 3 months, depending on the age of the patient. So a very severe disease. The UK is very fortunate in that you've got quite an organized approach to stroke care. You've had a national stroke strategy for some time. You have stroke unit care established across many areas of the United Kingdom. You have national sentinel audits, which evaluate stroke care periodically, and this has been established for some time. Canada was later jumping on that particular bandwagon. In approximately 2000 or 1999, disease advocates in Canada were calling for a national stroke strategy to deal with the aging population and the tsunami of stroke that was expected. Alberta tried to produce a strategy in the early 2000s, but it fizzled out. Ontario was the first province to be successful, but Alberta was successful in 2005, with funding delivered in 2006. The way we organized our strategy was to bring together the 9 Alberta health regions, which later merged into a super board called Alberta Health Services. The government, Alberta Health and Wellness, our equivalent of the Ministry of Health, who brought $42.5 million to the table to fund the strategy. The Heart and Stroke Foundation, which is a private charity or a disease advocacy organization which tries to further care and progress and research in cardiovascular diseases and stroke. And also stroke expert advisors. These are physicians, nurses, rehabilitation professionals, academics, and clinicians, all coming together to form the Alberta Stroke Council, which is the governing body of the provincial stroke strategy. We organized the provincial stroke strategy along pillars or committees. So these are committees, but also priorities. And they are health promotion and prevention, emergency services and acute care, rehabilitation and community reintegration, and evaluation and quality improvement. And I'm here because I chair the evaluation and quality improvement pillar of the provincial stroke strategy. If you want to learn more about it, we have a website that you can go to. The strategy was committed to improving or creating or assisting in the delivery of stroke services across the continuum, right from primary and secondary prevention to stroke recognition. This is education of the population on stroke risk factors, emergency management and acute care services, including TPA, thrombolysis, stroke unit care, rehabilitation, and community re-engagement. So these were the areas that we felt we needed to address across the continuum. And it was recognized that other initiatives would cut across all of those areas, including education, which is important to each of these areas, and also telehealth. Given the geographic challenges that exist in Alberta, it was felt that telehealth would be an important part of this strategy. And in fact, we've created telestroke services in the areas of prevention, acute treatment, and rehabilitation at this point in time. So that's where telehealth intersects with the continuum of stroke care. But for now, given the time constraints, I'm just going to talk about telehealth, or telestroke as we call it, in the delivery of acute care services for ischemic stroke in particular. There is a medication that most of you or some of you will be familiar with called tissue plasminogen activator, or TPA. And TPA is a clot-busting drug which has the potential to dissolve the clot that you saw in the left middle cerebral artery, restore blood flow and oxygen, and hopefully improve function. The drug is not a magic bullet, but it's a potent medical therapy. If you look at the green bars, there's a time-sensitive component to treatment. If you treat patients in less than 3 hours from onset, you have a 12% absolute increase in good outcome, which is defined very ambitiously for stroke as cure. You have a 12% increase in cure. There's a 30% relative increase in cure. If you treat in 3 to 4.5 hours, it's a 7% absolute, a 16% relative increase in cure. If you want to look for any kind of benefit, it's probably about a 30%. There's a 30% absolute increase in benefit if you give the drug. In other words, to improve a patient by 1 modified Rankin scale, you really only have to treat 3 to improve one person, but to cure, you have to treat 8. And that's the way it works. This more or less says the exact same thing. There's a dramatic linear decline in the effectiveness of the drug with ongoing time, and beyond 4.5 hours, it probably is not effective. currently, fewer than 8% of all ischemic stroke patients receive intravenous TPA across Canada and the United States. In fact, I actually think it's less than that. I'm not sure what the numbers are like in the UK. It might be slightly lower than that estimate. And in Germany, for example, some areas it's as high as 10% or more. So there's some variability across different countries and regions in terms of the proportion of patients that get this treatment. In Alberta, prior to the stroke strategy, in fiscal year 2004-2005, 8.6% of ischemic stroke patients received TPA, which was higher than the national average at that time at baseline. We found the greatest underuse of TPA occurred in rural regions where clear rural-urban care discrepancy exists. And the difference was infinite, from a 15% thrombolysis rate in tertiary care centers to a 0% thrombolysis rate in rural centers. I mean, there was absolutely no comparison whatsoever. There were obstacles to TPA use in rural Alberta. The lack of availability in some areas of CT scanning, especially very remote areas, lack of neurologist or experienced stroke physician coverage, a geographic area larger than the country of France, which creates long transport times, challenging weather at times with limited access by road, and high physician and nursing staff turnover. So a lot of these rural regions have difficulty hiring and retaining skilled medical professionals. And that's an obstacle if you're trying to educate a site to give thrombolysis. Back to the provincial stroke strategy for a moment. The evaluation plan uses a number of data sets to evaluate the effectiveness of the stroke strategy. A number of pre-existing data sets, including hospital discharge abstracts, but we created a number of new data sets, including chart reviews, electronic databases, as well as and a prospective TPA data set it's a minimum data sheet, which I'll tell you about in a moment, but it is to be filled out for every instance of thrombolysis in the province and either faxed or sent by secure file transfer to Pillar 4 or the Evaluation Pillar's central database. It involves active and passive surveillance. Active surveillance meaning ongoing real-time tracking of who gets TPA, as well as a review at the end of the year of administrative data and pharmacy data to see who received thrombolysis that wasn't caught by active surveillance. And the actual time for compliance varies, but most zones actually submit monthly. They submit this data monthly. And the data set is very basic. It contains demographics, hospital site, time last known to be normal or last seen well, arrival at an emergency department, the time the CT scan was completed, the time of the bolus of drug, whether there was neurological worsening with intracranial hemorrhage. This is the outcome, of course, that everybody who gives TPA is concerned about, whether you're giving it for myocardial infarction or stroke. There's about a 6% rate of intracranial hemorrhage, 6 to 7% with ischemic stroke when you use TPA. Now, having said that, as a group, the people that get TPA are better off, as I showed you. So as it turns out, the people that do worse from their baseline stroke are the ones that go on to hemorrhage. So you don't actually increase mortality, you reduce disability with the drug. And then there's also other major bleeding and whether or not telestroke was used or telehealth was used in the encounter. I'll tell you a little as well about the Northern and Southern Alberta telestroke programs. This is a hub and spoke model, not smoke and mirrors, but a hub and spoke. It's a different thing entirely. The northern hub is Edmonton, the center I work out of, and there are a number of spoke sites, and the southern hub is Calgary. To start with, the first center in Alberta was St. Mary's Hospital in Camrose, which was our first spoke center, and the hub was Edmonton. We created video conferencing links and PACS imaging. So we have a secure electronic system whereby the physician can do two things. Number one, access electronic data on the patient going back several years. I can see previous diagnostic images, look at lab results across the entire province for anybody in Alberta. And we have an online system whereby I can pull up their CT scan images from a secure internet site. And then we went to a total of 10 sites in the north and 3 sites in the south. And the program is activated and supported and could not function without a 24-hour critical care line service, which is staffed by emergency room triage nurses, which actually connects the physician in the rural area with the stroke neurologist. And if we get paged to Rapid North, we have a 2-minute response time. And if we don't respond, we get paged again. So this is one of the successes of the provincial stroke strategy and of our telehealth programs. We've gone from 5 centers in the province that could give TPA to 16, soon to be 17 in the next month, and shortly thereafter it'll be 18. And all of this increase, almost entirely, was within rural Alberta. So there's been over a 300% increase in centers that can give clot-busting drugs. Most of this is in the northern telestroke system. Just due to the geographic challenges from this system. There's a greater need for telehealth services. The southern system has fewer sites. These sites are larger. Some of them have neurologists on site, so it's less likely that you'll need telehealth, but they have about a third the volumes as the northern network does. What this entails is there are a lot more telehealth sites across the province, but these ones have telehealth equipment and connections in the emergency departments or the intensive care units, where we can actually examine patients via video conference and actually work with the physicians and nurses on that end to deliver thrombolysis therapies. And this is our clinical telehealth lead in Edmonton, Dr. Khan, examining a patient in Camrose and looking at his images on the computer at the same time to make a thrombolysis decision. And this is the portable video conferencing equipment that we carry around with us, which enables us, you basically plug this device into an internet port, and it encrypts its own signal and provides a secure line for examination of the patient and verbal and visual. We get a picture right into the emergency department. And we carry it around in a special case that looks like we're transporting a nuclear weapon or a kidney, although as a neurologist I wouldn't know what to do with a kidney. I understand it does serve some useful purpose. But I was drooling when George was telling me about they have a handheld app device, and so his physicians in Scotland can actually get this kind of technology on their handheld mobile phone, which we've been trying to do, but we're running into privacy problems within Alberta, but we're trying to circumvent those. So we recently examined outcomes in the Northern Telestroke Network. That's where we've got a complete data set at this point in time. For 4 years, there were 554 patients treated with TPA across Northern Alberta alone. There's actually another 500 in the south, which we'll be examining shortly. Of these, 119 received TPA using telestroke technology and 435 without telestroke technology. A primary stroke center is a center that can give TPA and provide other stroke services such as stroke unit care or stroke unit equivalent care. A comprehensive stroke center has neurologists on site, radiologists, neurosurgeons, interventional neuroradiologists, different level of care. Of those who received TPA using telestroke, all of them were from primary stroke centers. And in terms of those that did not require telestroke, most were from Edmonton, the comprehensive center, 2/3. But another third were from primary stroke centers who have neurologists or internists on site and more resources, and they didn't need to use telehealth or telestroke. In regards to intracranial hemorrhage, there was interesting variability from year to year, but the average rate of intracranial hemorrhage was 6.7% for non-telestroke thrombolysis and 5.5% for telestroke thrombolysis. So it was actually comparable. We actually feel that our definition of intracranial hemorrhage is an overestimate, so we're actually reviewing all of these cases. For example, the SITSMOST registry in Europe is a lot more conservative, but ours is close to NINS, but probably even more inclusive than NINS. So we're reviewing that to see whether or not this is an accurate description or not. It certainly won't go up, but it might come down after the validity work. The door-to-needle time for patients treated with telestroke versus not with telestroke was similar between the two groups. And the 30-day in-hospital mortality was similar as well. In this cohort of relatively severe strokes, around 15%, which is higher than the average mortality for stroke patients, but patients that are candidates for TPA tend to be a little bit more severe. We have functional outcomes for a subset of these patients. For those that have a modified Rankin scale of 0 or 1, it's about 40% across the Northern Telestroke program, and that compares favorably with the NINS TPA group and is higher than the NINS placebo group. And if you think, well, if you're pouring TPA over all these patients in rural Alberta, are you sure they're not dying from something else? And so that's a good question. And we looked at stroke mortality in the province, and in fact it had plateaued for several years prior. But after the stroke strategy was implemented, and this coincides with the introduction of telestroke as well, we've seen a 28% reduction in mortality for hemorrhagic stroke, a 27% reduction in mortality for ischemic stroke, and a 20% reduction across all strokes. So there's really no evidence of an increased mortality, and if anything, possibly not just due to telestroke, mortality is decreasing, and that's just over 4 years, and that's probably 50% or more greater than the declines in the rest of Canada over this period of time. So TPA is considered a dominant strategy, especially in North America. A recent meta-analysis suggested it's a very cost-effective, looking at global perspective. What that means is if you take a group of patients that gets TPA versus that don't, those that get TPA have better outcomes and cost less. So it's not cost per quality, it's cost savings per quality adjusted life here. So you call that a dominant strategy, or in Northern Canada we call it a no-brainer strategy. And we estimate we save approximately $200,000 a year from the use of TPA, looking at cost effectiveness projections. If we treated 20% of ischemic stroke, we'd save about $308,000 per year, or $1.7 million in 30-year costs. Now that's not an astronomical amount, but again, you're saving money to improve outcomes. So it makes a lot of sense. We've also reduced transfers of acute stroke patients from the entire north of the province to the University Hospital emergency room by 29%, which is a savings of $300,000 per year just in transport costs alone. From some centers, there's been a 92% reduction in transfers, 92%. They've been able to manage their patients locally using telestroke support and also local resources as well. So to summarize, Alberta has used telestroke personnel and technology to improve access to thrombolysis over large geographic areas. Even one hub site can allow access for as many as 10 primary stroke centers. We did not find a difference in mortality, hemorrhage rate, or door-to-needle time between telestroke and non-telestroke centers, at least in the Northern Stroke Network. But we are doing a detailed cost-effectiveness analysis, which is pending. We'll be writing the final report of the provincial stroke strategy this year, and that will be part of that report. In regards to the patient, she was seen urgently and transferred to a primary stroke center where she did receive TPA using telehealth. She ended up having a small infarct, a lot smaller than what might have been possible. Her weakness actually resolved. She had a mild facial droop and was discharged home just days after her acute presentation. So she's an example of a good outcome in that situation. Thank you. I'd be happy to I guess I'd be happy to entertain questions after the next speaker.